Welcome to this presentation from the Center for Community-Driven Research about the Personal Experience, Expectations and Knowledge Program, which of course is known as the PEAK Program. CCDR is a non-profit organization with a vision to create a more person-driven health sector. We have three clear goals: to provide a platform for patients and their families to engage in decisions about health, to conduct research so that we can understand patient experience and expectations and inform future treatments, services, support and information, and to test approaches to community engagement and service provision to build capacity within the non-profit sector. There are many guiding documents and charters that steer our work in community engagement. At CCDR, as a community-based organization, we are always reminded that for whatever we do, at the heart of this process is the empowerment of communities, their ownership and control of their own endeavors and destinies. Let's take a high-level look now at PEAK methodology. PEAK studies use a single protocol. They are mixed methodology studies, including an online questionnaire and structured interview. This approach is used as our aim is to have routine, proactive collection of patient experience and expectation data by an independent agency. All reports are publicly available reports, and collectively this results in a repository of patient experience data with transparent and systematic presentation of results. We'll aim to repeat studies at clinically relevant intervals or periodically. And the program is the result of 2 years protocol testing plus 2 years testing feasibility. An important aspect to any kind of research is generalizability. And in the context of PEAK studies, and in the context of mixed methodology research, the way that this is addressed is by having a multi-dimensional protocol that can be cross-validated and covers a holistic range of domains. Participants in PEAK studies have the chance to reflect on everything they have experienced. Then, acknowledging that they hold their own expertise, we ask them what their expectations and recommendations are for the future. This gives us all some direction in the way decisions need to be made about treatment, care, information, and communication. Each study is presented in a consistent way on a dashboard. As each study is released, our repository of patient experience data and reports grows. This means that everyone can access information about patient experience and use this to inform their work and drive more person-centered decisions. Over a 2-year period, and at the end of the feasibility testing, CCDR had conducted 1,054 interviews with participants across 16 disease areas. The average length of the interviews was around 48 minutes, and you can see that the average length of interview varies across some of the disease areas where the examples are shown. It's important to understand that just because the average length of interview may vary, it doesn't mean that one patient population is more talkative or has more to offer. Some of the reasons for variation in length of interview relate to opportunity. If we take the question we ask about treatments experienced, for example, in the SMA study, participants did not have any treatments available, and you can see from these examples that the response to that question was quite short. This, of course, is much different for disease areas where there are potentially multiple treatment options. As a general rule and going forward, CCDR will aim to have 100 participants per PEAK study, unless it is a rare disease where that isn't possible. In each PEAK study, a review is done to see what other quality of life or patient experience studies have been done that include an interview component. We find that PEAK studies usually have the largest number of participants interviewed and also provide the most breadth of information as they cover such a wide range of domains. By including such a strong number of participant interviews, it means that we have more confidence in the themes that come through and that we can conduct a subgroup analysis which isn't possible in smaller cohorts. CCDR has a fit-for-purpose research team to conduct the analysis of data. For the analysis of qualitative data, we start by de-identifying the interview transcripts, and that includes removing any names or places. 2 researchers then each do an analysis of the interviews. We have some standard themes that we look for across studies, and they also identify new and unique themes. We then cross-check that the results of the analysis are the same, and where they aren't, come to consensus on what code should be applied to the next. We then do a final check and make sure we haven't missed any sub-themes. On the quantitative side, first we de-identify the data. Then we conduct the analysis, and once it's finished, we set that aside. The analysis is conducted a second time and both sets of results are compared to make sure the results are accurate. Because we have both qualitative and quantitative results, we can use these to cross-validate the responses given by participants. Let's take a look now at the domains and questions that make up the PEAK methodology. Section 1, Introduction and Methodology, is where you can read about the PEAK methodology, information about the recruitment period and approach. There is also a review of other mixed methodology studies in the field to identify the position of the PEAK study in the context of other literature. PEAK studies are often the largest of their kind in depth, breadth of questions, and participant numbers. Section 2, the demographic section, is where you can find information about the study cohort. This is also where the subgroups used throughout the study are described and where the baseline health of the cohort is described using the SF36 questionnaire. This is a summary of the questions we ask in Section 2, and these all come from the online questionnaire. Section 3, the Symptoms and Diagnosis section, is where you can find information about experience of symptoms before diagnosis, as well as the symptoms that led to the diagnosis. There is information about the diagnostic tests that were performed, where the tests were conducted, and the time from tests to diagnosis. In this section, there is also information about the participants' understanding of their condition and their understanding of their prognosis. This is a summary of the questions we ask in Section 3. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. Section 4, the decision-making section. You can find information about the conversations that were had about treatment options at diagnosis, what is important to people when they make decisions about treatment, and whether decision-making changes over time. All of this information comes from the structured interview. Section 5, the treatment section, is one of the largest sections in each study. Information is available relating to the types of treatments people have experienced, as well as rating quality of life and effectiveness for each treatment. There is information about the main providers of treatment, access to health professionals, and information about which part of the health system participants were treated in. There is information about affordability of healthcare, any reduced income for the patient or their family, any additional costs or changes to employment. There is then also detailed information about the treatments that the participants have experienced, whether they had any side effects, the description of mild side effects and severe side effects, and any complementary therapies that they may have used. Information in relation to access to allied health is also available. Information about what needs to change to feel like treatment is effective and adherence to treatment is also presented. In this section, there is also information on whether discussions about clinical trials were held with clinicians, and for those who have been on a trial, what their experience was like. This is a summary of the questions we ask in Section 5. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. Section 6 reports on access to information, information that was helpful, and information that was not helpful when participants feel they were most receptive to receiving information preferences, information topics for which information was received or searched for, as well as when it was received and additional information was required. This is also when there is information about healthcare professional communication and participants' knowledge and confidence in managing their own health using the Partners in Health tool. This is a summary of the questions we ask in Section 6. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. In Section 7, a care coordination questionnaire tool is used and reported in this section to demonstrate how people have been able to navigate the health system. There is also information about the care and support people have received. This is a summary of the questions we ask in Section 7. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. In Section 8, information is available relating to the impact that the condition or disease has on quality of life, regular activities to maintain mental health, regular activities to maintain physical health, impact on relationships, impact on family and relationships, cost considerations. The fear of progression tool is used and reported here to describe the level of anxiety that participants may have in relation to their condition. This is a summary of the questions we ask in Section 8. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. By the time participants are asked questions about their expectations of the future, they have had the chance to talk about everything that they have been through. It means that they have been able to reflect on what worked for them and what was potentially not so great. In Section 9, there is information about what participants would like to see from future treatments, information, care, and communication. We present the cohort's message to decision makers about their condition and the values that are important to them when they make decisions about treatment and care. In this section, there is also information about what people have been grateful for. This is a summary of the questions we ask in Section 9. The questions in the blue box come from the structured interview, and those in grey boxes come from the online questionnaire. In Section 10, we present the response to the question, "What is your advice to other people who are diagnosed in the future?" This gives participants the chance to impart knowledge and for patients to feel connected with others in the community. Section 11 provides a review of the current landscape across all of the PEAK domains and commentary on how the PEAK cohort's experience compares to the literature. The final section summarizes 3 key things that would make life better for people with the condition or disease. There is also a matrix of key findings so that when we repeat the project in the future with a new cohort, we can see whether their experience has improved. For more information about PEAK studies and to access reports, go to www.cc-dr.org/PEAK.